And here's a picture of the nephron in the kidney, just to kind of remind you. The afferent arteriole and then the efferent, and in here is where everything is filtered out from the blood and into the nephron here and down to the loop of Henle, where the things that we need to reabsorb are reabsorbed into these capillaries here, and then what's left, the urine, is brought down to a collecting duct and then down to the bladder. And here's the same picture, but stretching out that loop of Henle with showing you what is reabsorbed at the different locations of it. And this should just kind of be a review from anatomy. Okay, urinary tract infection. Fairly common problem for the urinary system. And one of the reasons we have this, little girls have such a short urethra that it's very easy for germs from the outside to get in. Boys, we see a higher incidence of UTIs when they're uncircumcised. American Association of Pediatrics doesn't recommend circumcision because the amount of problems you have from circumcision, whether it be an infection at the site or something, is equal to the problems we see of UTI. So urinary stasis, so urine just sitting in the bladder and not fully emptying, is what allows bacterial growth to happen. Reflux, and I have a picture that'll show that in a little bit. And overdistension of the bladder. When the bladder is very distended, the blood supply to the bladder itself, to the wall of the organ, isn't good. It's stretched out. We're pinching off some of the vessels. When that happens, if we have germs in the urine, they get a chance to invade into the bladder tissue of that bladder wall. So the urine itself is supposed to be sterile. The problem is when you put it at body temperature, it becomes a perfect medium for growth. So if you do get some germs in, they can multiply there, and then you over-distend that bladder, kind of compromising the bladder wall, and the germs get a chance to invade. Urine should also be a little bit acidic, which makes it less desirable for bacteria. It's a little harder for bacteria to multiply in an acidic environment, but it doesn't totally prevent it, it just decreases it. We treat UTIs with antibiotic therapy, and the usual cause is this reflux, and I have a picture of that coming up. So again, some of the problems is that short urethra on girls. So what do we want to do? We want to make sure parents are wiping front to back. Remember, urethra we want sterile, the vagina is clean, the anus is dirty. So we want to always be wiping that direction, front to back, from clean to dirty. Avoiding really tight clothing or diapers. An older girl wearing cotton panties rather than nylon will all help. Avoiding scratching and things like that. And then incomplete emptying and overdistension we want to avoid. So when kids say they need to go, not try and hold it. And then encourage them to empty their bladder completely. And straining at stool. If kids who are constipated, the full rectum can push on the bladder or those urinary structures and make them not completely empty the bladder. And then concentrated or alkaline urine, so we want to encourage lots of fluids. And here's what happens with that reflux. Normally, your bladder fills up with urine. There's a little valve here between the ureter and the bladder, leading out, this is out to the urethra, and this valve closes when this is full, and then the bladder empties and it's empty, it's done. If you have a reflux, this valve doesn't quite close, so as this distends, some of the urine flushes back up here into the ureter. You empty the bladder, but then the the urine that had gone back comes out. So you've got this urine that never actually left, and that's that urinary stasis, and that's the urine that we're worried just has too long in the body at body temperature to start growing bacteria. So that's a UTI. The next thing we're going to talk about is obstructive problems, obstructive uropathy. And what happens here, wherever the obstruction is, the urine is going to back up beyond that, which is hydronephrosis, which we're going to get dilation, stretching out at the point where it can't go through, where it suddenly goes from the garden hose down to the straw. So it's going to dilate there. As you stretch it out, the pressure is going up, and that pressure is what does damage to the structures. Now, obstructions, they can be one side, both sides, complete, partial, upper, lower, any part of the urinary tract. And this picture shows some of the common areas for them to be. You can see stricture here, a band from some scar tissue from something else that's pinched it off there, and here's some stenosis. Can be down in your urethra, and then you've got, here's a big hydronephrosis area, and we've developed polycystic kidney. See all these little cysts as it's backing up because it can't get down past these. The pressure builds up back here, and you end up doing this damage. Moving on to defects of the GU tract. Inguinal hernias. This is where a loop of intestine slips down into the scrotum. A hydrocele looks similar to a hernia, except it's fluid as opposed to a loop of intestine. Phimosis. This is a foreskin that can't be retracted. Now realize it's normal on young boys, infants, toddlers, even school-age boys. Up until puberty it can be normal for this foreskin to not be retractable. So this is really and that's okay, that's fairly normal. After puberty it needs to be retractable. Hypospadias. The urinary meatus comes out somewhere along the bottom of the shaft of the penis instead of at the tip of the penis. Epispadias is the opposite. The meatus comes out somewhere along the top of the shaft. Your cryptorchidism, your undescended testicles, normally they develop in utero up in the abdomen and then come down, hopefully by birth, and if not, we bring those down because they have a higher incident of cancer, testicular cancer, if they're left up in the abdomen. And exstrophy of the bladder. This is where the bladder is external from the abdominal wall. I've only seen that a couple times, not terribly common. It usually goes along with some abnormal genitalia. And then, very sad, sometimes we see ambiguous genitalia where it's not clear if it's male or female. And here's some pictures. Here's our loop of intestine, and our testes are back behind there. So down into the scrotum we've got that big loop of intestine. Here's what should be happening in utero as the testy is developing and scooting along and sliding down into the scrotal sac here. And this is what you should end up with. This one, it didn't quite separate the way it should. Here we've got our hernia because a loop of intestine came down. This is our hydrocele. It looks the same, but this is a fluid-filled sac as opposed to a loop of intestine. This usually will absorb on its own, and if it doesn't absorb by a year or so, then they may go in and take this out. This depends. As long as the testes is down, it's probably something they're going to watch, and wait a little bit. If the testy hasn't come down, then they'll pull down the testy and push that up and tighten up the inguinal canal there. As long as this is soft and reducible, so you can push it back up where it should be and it's very soft, and the testes down, it's going to depend, but they may actually wait a little while and see if that inguinal canal there will tighten up on its own and it stops coming down. Here's the hypospadias. Here's our urinary meatus, which should be up here at the tip of the glans penis, and instead it's down here on the shaft. This is actually fairly common. This is one of the things that students get to see quite often, is the repair for that in OR. Exstrophy of the bladder. So this is a bladder that's just outside instead of inside, and as I said, it usually does some problems where the genitalia will also have to be reconstructed. So this is fairly complicated reconstructive surgery that takes some time. And similar to the gastroschisis, when things are born on the outside, if you just push them in and close it up, you increase too much pressure and pinch off blood supply, and you can end up with problems. So you have to do it a little bit slowly and carefully. We saw this not too long ago at the hospital, where it was actually a little girl, and they were keeping just a moist 4x4 over it for the short term until she had grown enough that they could go in and do the surgery. Here's another exstrophy up here, not quite as much of the bladder, but some out, and this has an epispadias. Here's our meatus up here. Okay, moving on to nephrotic syndrome. Nephrotic syndrome is these kids suddenly develop severe edema. What happens is protein in the urine, the kidney stops. It's not supposed to be permeable to protein, but it allows protein to spill out and go out in the urine. So you get this proteinuria and hypoalbuminemia, because the albumin is the protein in the blood that shouldn't be going out in the urine, but it is. So we have not enough albumin in the blood, and instead we're seeing protein in the urine. And along with that, they develop this hypercholesterolemia. Not the mechanism of why that happens is not 100% understood. The treatment is steroids. The first treatment is to give them steroids. We can also give them albumin. Remember, we lost all this albumin here. We might need to give them Lasix to get rid of that fluid that's turned into edema. We want to prevent infection, and we may need to do a low salt diet, and if it's really severe, we may need to restrict their fluids because the fluids are just making edema. And here's a little boy who is, you can see, very swollen. Kids tend to get this periorbital edema. He's got ascites, so the abdomen is very distended, and he's just plain edematous all over. Here's a picture from your textbook of what happens. So we have the problem in the kidney where the protein is spilling out, causing protein in the urine and not enough in the blood. Because we don't have that protein in the blood, that's normally is what makes that oncotic pull to keep fluids in the blood. So it's not, the fluids are moving out into the tissue, which decreases our circulating blood volume. Because we have less blood volume, we're going to do, our kidneys are going to do that renin, angiotensin, and ADH, trying to reabsorb water and fluids to keep from getting, to counteract that hypovolemia, and that fluid is just continuing to shift out and make edema. Now, the treatment for nephrotic syndrome, I said the first treatment is corticosteroids, and those are for months. It's not a short-term thing. Usually these kids look better within a short time, but we keep them on the steroids for months Probably low salt diet, may need a fluid restriction, we may need to give some albumin,